nutrition and physical activity combined. Quite a lot of studies, 15 studies, 50 outcomes, so quite enough data here to come to some conclusions. Beneficial outcomes 23, no effect outcomes 27, and harmful outcomes 0. Typically, if we were expecting the outcome to be no effect at all, we would expect to see a number of harmful outcomes coming through as well. And so because everything's either in the middle of the table or to the left of the table there, we're expecting that it suggests to us that there probably is some sort of effect, and it's somewhere between no effect and a beneficial outcome. As I've been saying, going through as the time of follow-up becomes longer, there's been a tendency to no effect. That's more diluted in this finding. You'll see in that 9 of the beneficial outcomes were from studies with less than 12 months follow-up. That leaves 14 of those 23 of beneficial outcomes from studies of greater than 12 months. So certainly we're starting to see some beneficial outcomes being sustained beyond 12 months when nutrition and physical activity interventions are combined in a primary care setting, when you're looking at outcomes such as blood glucose, blood lipids, blood pressure, and anthropometry. Some of the key points from the analysis: as the follow-up time increased, effectiveness tended to no effect, especially for the physical activity and the nutrition only, less so for the combined physical activity and nutrition, but there was still a little bit of that going on. The interventions with no effect had very similar features to the effective interventions. So for example, what we'd hope to see, or maybe expect to see, is that interventions which were had no effect, we might expect to see, for example, that they didn't provide targeted advice, that maybe they didn't do individualized goal setting, maybe they didn't have as long in contact time, maybe they didn't have as long in frequency of contact, or multiple aspects to the intervention, or maybe they didn't have a theory base or so on, but we didn't see that at all. So when we were looking at the features of effective interventions and those with no effect, there was really no obvious or explainable differences between the interventions that were working and the ones which were not working. In fact, some of the ones which didn't work looked like they were incredibly well run and amazingly well resourced, and they were still having no effect. And yet some of the smaller, very discrete interventions were actually having an effect in some situations as well. Effect sizes were very widely spread. That means that the effect of nutrition and physical activities had changes in outcomes, such as body weight, that were either similar, or they were higher, or they were lower than those nutrition-only and activity-only interventions. So for example, you might have expected it in those combined physical activity and nutrition interventions that they would have a bigger effect on blood pressure or a bigger effect on weight than just the nutrition-only ones or physical activity-only ones, which happened to be effective. But again, the effect sizes were very mixed across all of the study types, and so some of the nutrition-only, for example, were getting quite reasonable size effects, and some small ones as well, and that was the same case for the physical activity and nutrition combined as well. So there's quite a lot of unexplained features of effective interventions, and also unexplained effect sizes as well. Despite not achieving changes to the biological endpoints, which is the key aspect of our literature review, the studies often achieve changes in other measures such as improved quality of life scores or increased time being spent active, and New Zealand's Green Prescription Intervention was a good example of that. So for the individual studies, they had potentially good results in other areas other than biochemical. We did, just to double check, we thought, crikey, maybe we're being a bit harsh here, and we're just focusing on biochemical, and actually we're getting really good changes in, say, fruit and vegetable intakes or something like that. So we looked at fruit and vegetable intakes, minutes reported to be exercise and so on, and across all of the studies, again, it was a really mixed bag, and we weren't finding any obvious effectiveness statements that we could make from that. And that's all unreported in the document, but we just thought we'd better check on that just in case we were missing something, but it certainly didn't appear that we were. What's our summaries then? Well, getting back to the World Cancer Research Fund, they have this word limited suggestive to judge some evidence, and so that's the grading that we ended up with. So we came up with there is limited suggested evidence that physical activity interventions have no effect. So a limited suggestive piece of evidence allows you to judge what direction the effect might be, and for physical activity interventions we think that there's actually enough evidence to show to suggest that there is actually no effect. All of the studies are, apart from, or three of the 27 outcomes were showing a positive impact, but 27 were showing no effect. So the effect is actually no effect. That's the suggestion anyway. Nutrition and activity interventions are effective, and there's limited suggestive evidence for that. And as you recall back to that slide of the nutrition and physical activity combined, we would have expected to have had some harmful results if there was actually a no effect result, or at least we would have expected far more in the no effect column, but in fact there were quite a large number of beneficial outcomes. What does limited suggestive mean? It's the lowest possible level of evidence, and it suggests a direction of effect. So there's no hand on heart carry on going on here. We're just suggesting that this might be the direction of effect. So we're suggesting for physical activity that there's no effect, the direction is no effect, and for physical activity and nutrition combined, we're suggesting that the effective direction, the direction is effective. You give it this grading when there are either few studies providing results and or evidence may have methodological flaws, and or there's unexplained heterogeneity of effect, that is a mishmash of results. And certainly there was an awful lot of unexplained heterogeneity of effect going on here. The difference between the no effect and the effectiveness was quite stark, and we were unable to pick apart what was potentially going on there. World Cancer Research Fund also say, whatever you do, don't implement policy or practice recommendations based on this level of evidence. So they wouldn't expect you to implement physical activity or physical activity and nutrition combined interventions based on this level of effectiveness. And so keep that in mind when you get to our recommendation slides which are coming up. For nutrition only, because there were less than 4 studies, the nutrition interventions has been graded as limited non-conclusive. So we're not even going to suggest what the direction of effect is. We just literally don't know, and we don't know whether what the direction of effect might be for altering biochemical or physical endpoints in a primary care setting for individual adults requiring primary prevention. And of course, looking back at that nutrition only, there was also quite a lot of heterogeneity of effect as well. Let's just recap. There were no studies that reported harm, so that's a good thing. So going on to our recommendations based on that, the individual level primary prevention interventions in the primary care sector for altering biochemical or physical endpoints via nutrition and physical activity interventions are not recommended. And remember, that comes out of the World Cancer Research Fund saying you shouldn't be making implementation or interventions based on this level of evidence. It's the lowest form of evidence that's available, so don't be making practice or policy interventions around that. Now, it's really important to note that this recommendation relates to primary prevention only for nutrition and physical activity in the primary care sector, and not to treatment within the primary care sector. So we didn't look at the treatment component within the primary care sector. We were very focused on the primary prevention only. Population level interventions and settings other than those in the health sector might offer more promise for primary prevention. So for example, we know that primary prevention within New Zealand and at the school setting is effective. We've got 2 really good primary prevention randomised control trial type interventions that are run. One is Apples and one is Project Energize, both with highly effective outcomes and at primary level, primary prevention. So other population level interventions might well offer more scope. Grant Schofield does an awful lot of work in the workplaces around primary prevention, and I do an awful lot of work in local government settings with primary prevention. And anyone who knows about OPAL, for example, will know that OPAL works at a local government level. If however, you're going to do some sort of individual level primary prevention program in a primary care setting, or if you're going to suggest that they are undertaken, we'd strongly recommend that you do some sort of active research alongside that to see whether or not the intervention is effective at changing biological endpoints. Now, you might be wanting to change other endpoints other than biological ones, but we would encourage you to consider the biological ones as well. This study was a literature review, and if anyone was going to get into addressing primary prevention at the primary care level, we get the impression that there's actually quite a lot to unpack in primary care around primary prevention. So what are the barriers and the facilitators at an institutional level, at a health professional level, and at a patient level, and what is happening with the patient journey, the funding pathways to support primary prevention. What's the patient expectations for primary prevention? Do you go to a GP to expect to be healthy and to be told to stay healthy and be given an intervention to keep you healthy? What's the sector's expectations around that? And also, of course, other links with other health sector components. So there's quite a lot of potential work there if people wanted to get into it. And you certainly wouldn't use a literature review methodology to try and answer any of those questions. If I could sum up the findings in a couple of sentences, I suppose the first thing is don't throw the baby out with the bathwater. We didn't look at physical activity and nutrition preventions for treatment in primary care. So if you're sitting there thinking, oh no, nutrition and physical activity don't work in primary care, that's not what we're saying. We're saying they appear to be less effective. Certainly nutrition only and physical activity only don't appear to be effective for primary prevention, and we're not talking about treatment in the primary care sector. And if you are going to do anything around primary prevention, then I suppose the best one was physical activity and nutrition, but remember the World Cancer Research Foundation Fund and ourselves are suggesting that there's still not strong enough evidence to actually implement programs within this area. But if you do decide to go down that route, please have some good biochemical outcome measures as part of your evaluation program. Thank you very much for listening, everyone. And